Welcome to the 9th Annual Global Oral Health Symposium here at UCSF School of Dentistry. Good afternoon. I'm Lisa Behrens, not Ben Chaffee. You might all be wondering what could possibly have kept Ben away from being here today. Those of us that know him well, hardly anything comes between him and his work. But I assure you, there is a good reason, a very happy reason, a 6-pound and I think 12-ounce reason. Dr. Chaffee became a father this past weekend. And so, where's the camera? Ben, if you're watching, which I'm sure you will at some point after all the sleepless nights are over, not that they ever end. I, along with everybody here in this room, would like to congratulate you. So if we can all give Ben a round of applause. I'm actually really happy to be able to jump in because about 8 months ago, around now, he did the same for me. When I went on maternity leave, he covered the summer research fellowship program. And so when he asked me to cover today, I was very, very happy to do so. So I welcome you all. We have a great program this afternoon. The theme, Improving Global Health Action and Education from Theory to Practice. We have a wonderful lineup of speakers. And special thanks to the Philip R. Lee Institute of Health Policy, who is co-hosting this event, as well as providing the recording. Before we begin, I'd like to invite Dean Reddy to come up and say a few words.
Well, thanks. It's really exciting to be here, and it's pretty impressive that this is the 9th Global Symposium. And it's a pleasure to welcome you all to this event and to UCSF. You know, for nearly a decade, this has highlighted some of the brightest and most impactful research in the realm of oral global health. This year's theme I really liked when I saw that. I was pretty excited about that because it's essential that we forge a pathway from theory that will evolve into practice and really making a difference. The ultimate value of research is finding a new way to address problems that plague humanity and that are both here and around the world. And as the world gets smaller, we face a lot of challenges, and the solutions we seek call for creativity, collaboration, and commitment. Our mission at UCSF is pretty simple. It's advancing health worldwide. And it's wonderful to see how the program with Ben Chaffee as the leadership has come together and convenes change makers that come from all 4 corners of the world to discuss their work and in turn to inspire us as we do our work here today. We're excited that Dr. Chaffee is busy expanding the public, and in the meantime, we'll be concerned with health. But I hope today you find the speakers that are inspiring. I hope they energize you and propel you in your own efforts toward making a positive change in global oral health. So I'd like to thank Ben and the organizing committee for putting this together. I know they did a great deal of work, and I'd like to thank all of you for being here today with us. Thank you very much. And I'd like to turn the podium over to John Greenspan so we can introduce our first speaker.
Thank you very much. Well, I have the pleasure of introducing our good friend of UCSF, Dr. Brittany Seymour from Harvard. Her impressive CV and the abstract of her presentation on an education journey building the global health learning Helix. Helix. Are you trying to get into the molecular biology thing? Are nicely articulated in the program. So let me tell you about the Brittany I know. When we started this program about 10 years ago, I contacted the deans of what I thought were the sort of leading dental schools in the field and suggested that we get together and establish a global oral health, group within the consortium of universities for global health, which Haile Debas, our former Chancellor and Dean of Medicine, had established in the early 2000s. Haile and the executive committee of CUGH were extremely enthusiastic. In fact, we were the first interest group and still are, I think, one of the leading ones. And we had a symposium that we'd managed to organize that year in Montreal at the meeting of CUGH 2011. And so I convened a meeting of the emerging leadership, and Bruce agreed to lead it with me. But when I spoke to Bruce, he said, John, I'm used to leading things, but I don't actually know much about global health. He said, I went to England once. Does that count? Well, in those days it probably did. And he said, but I do have a star for you. And his star was a very junior dentist who'd come to Harvard to do an MPH from Colorado, where she'd done her DDS. And she was just finishing her MPH, and she was immediately snatched up for a custom-created fellowship at Harvard, which involved sending her off to some of the stars in public health at Harvard and in global health, the emerging global health program, to be the nexus for what was to become what has been a very successful global oral health program at Harvard. And we met, and she and the others who were starting this group in CUGH hit it off enormously. And indeed, she was so obviously, an emerging star that when I stepped down in 2014, the group asked her if she would take over that global oral health interest group, and she has, and she's taken it to very different levels of involvement. And what I love is the fact that we've moved from just finding out what's going on in global health, what is the nature of the disease, the patterns, where is it, to what can we do about it. Not just using the existing models of flying people in the helicopter dentistry kind of thing, but something much more profound. And she's brought together some very talented people, and that's what she's going to talk about. Thank you.
Very kind introduction. I'm going to see if I can get onto my presentation. Thank you. So I do want to say Dr. Greenspan has been a really important champion for me and a mentor, and I just want to make sure that you all know how grateful I am. I have so much gratitude that you recognized potential for me as a newcomer into this field of academia and global oral health. Global health was not even a term I uttered while in dental school, so it was all very new for me and for many. So I just want to thank you for your mentorship and that very generous introduction. So I'm gonna discuss the education journey that I've been on and how we have worked to develop what we're calling the Global Health Learning Helix, which is a curriculum model. I'm very passionate about students. I have many different irons in the fire within global health, but education and education of students is one of my greatest passions, and so that's the topic that I have the privilege of talking with you about today. And so I really want to thank you for having me and giving me the opportunity to share what we've done since 2011. I'm going to begin with asking a question. In a globalizing world, what is the role of the dental profession today? I think you'll hear me say for the first time, many times during my talk. A lot has happened only in the last decade. A lot has changed even since I was in dental school. And so how do we develop a responsive workforce in today's world? I thought before I launch in, of course I've got some data and some graphs and slides because that's what we do in public health, but I thought I would start with a personal story. And my story may not be readily apparent how it connects to this question right away, but I will tie it back at the end. All right. The green dress that kindled an unlikely friendship and showed us all the universal language of childhood. Last year, while working in Costa Rica, I had the honor of visiting La Casona de Cotobruz indigenous territory and met Merita, selling her handmade crafts. I wanted to bring home a souvenir for my 4-year-old daughter, Taylor Lane. Her daughter, Maxima, the same age as Taylor Lane, picked out a beautiful green dress and modeled it for me. The dress traveled 4,400 miles back from the rural tropics to wintry Boston. Taylor Lane loved it, and I sent a photo of her wearing it to my colleagues, asking them to please share it with Maxima. The dress sparked a long-distance friendship between the two girls, and I became determined to figure out a way for them to meet. This year, this January actually, my colleagues arranged an opportunity when we could come back to Maxima's community. Taylor Lane and I traveled back to Costa Rica and took the bus into La Casona. Many times leading up to the meeting, very excited but apprehensive, Taylor Lane asked how the girls would play if they didn't speak the same language. I was never worried. When we arrived to the point where the bus could no longer travel and we would need to go the rest of the way by foot, my colleagues were there to greet us and said Maxima had been asking all morning when Taylor Lane was going to arrive. We got off the bus and crossed the large, distinctive bridge into Maxima's community. Walking up the rocky trail ahead, I saw Merita and a timid but excited young girl peeking around her skirt. I couldn't tell right away if it was Maxima. She had grown since I'd last seen her. But as we approached, her distinguishing dimples revealed themselves, and I knew undeniably, yep, that's Maxima. After the initial shyness subsided, our two girls began running, laughing, and playing. They squeezed every minute out of their time together until we knew the bus could not wait another moment. It was time to cross the bridge back and say goodbye. Two girls whose lives could not seem more different, one from a high-rise in Boston and the other from a hut in La Casona Indigenous Territory, formed an instant bond before my eyes. In a world where we are too distracted by differences and focused on building walls, these girls crossed a bridge and saw that they are the same, and that indeed they speak the same language after all, the universal language of childhood. Perhaps if we stop looking for differences and start noticing how we are the same, perhaps instead of building walls, we can build bridges, like the one Taylor Lane crossed to meet Maxima while wearing her green dress. So as we think about what is the role of the dental profession, let's think about our world. And this is where I'm going to talk about the firsts. So when I teach my own students back at Harvard, I often start with a slide like this, and I ask them, without the dates and the answers, I just show the slide and I give them one rule. They have to choose. Which one do you think there's more of in the world? More people older than 65 or under the age of 5. And really, only since around 2007, for the first time, our world is older than younger. Same with people living in urban areas versus rural. In about 2009, we saw that change. In 2011, people have now more cell phones than working toilets. And we know, most of us in this room are aware, that there are more untreated caries in the world than all forms of cancer combined. So all of this has happened since I graduated dental school, really in the last decade only. And so what does this mean for the way we're teaching our students and how we respond to these things that either directly or indirectly impact our professional responsibility to our patients, our communities, and the world? All right, so this slide doesn't look that exciting, but it is one of my favorite slides that I've ever put together. This is one of my, these are some of my favorite highlights in recent history of global health and development. So I'm going to start with 1990. In 1990, this was the first, now this is not that long ago, again, more firsts, okay? So in 1990, this was the first time that we saw a systematic global burden of disease study occur at the global level, where we could start looking comparatively at disease burden between countries. And not only was that exciting, but also we started considering not just what people are dying from, but what's making them sick and keeping them sick. This is when morbidity became a meaningful measure. So not just mortality, but what kind of diseases and illnesses are impacting people's quality of life and the length of life they live. And this is important for us in oral health because we're often managing and controlling illness that may not lead to mortality, but that we know significantly impacts the well-being of people's lives. So in 1990, that was a pretty unprecedented level of study. And only a few years later, the World Bank released the World Development Report. Now, how many of you know about the World Development Report? A few, but not very many. This is such an amazing year, 1993. I always tell my students, every dentist should know this. Every health provider should know what happened in 1993. So every year the World Bank releases their World Development Report. It's kind of like a state of the economic and social state of the world from the World Bank's perspective. And in 1993, their report focused on health, which was the first time ever. But what was remarkable is that they demonstrated through data and through the study that had come out in 1990, they demonstrated that an investment in health can lead to improved economic outcomes. So the prior consensus generally was, before that report, before this data was available, that if we can just lift people out of poverty, then we can get them healthy. So there was a strong focus on investing in economics with health as an outcome. Now that's still true, but they turned that on its head. They demonstrated with real data and a lot of impressive modeling that if we invest in health, we can lift people out of poverty. That's a game changer, and that has been a game changer since then. And sure enough, in 2000, when world leaders came together for the UN Millennium Summit, very exciting, to discuss how do we eradicate extreme poverty in the world. The world is growing. There are vast numbers of people living in poverty. So they developed the Millennium Declaration, and out of that came the 8 Millennium Development Goals, which may or may not ring a bell, but all world leaders signed on to achieving these goals. And the overall aim of these goals was to eliminate extreme poverty. And guess what? Several of those goals had a specific focus on health and investing in health. That's an amazing turn of events where global leaders came together and decided as a world, we need to invest in health and respond to the changing world to get people out of poverty. So for my students that are getting into healthcare now, who may not recognize what a tipping point that was for health in the world, I tell them, I think this is the most exciting, most challenging time to become a health provider ever. And I'm so excited that early in my own career, I was able to make that switch and get involved, and that I have the privilege of doing this work today. All right, so this brings us to 2010, when the second global burden of disease study took place. And what can you do once you have 2 of something? I heard you can compare. So now we have 2 sets of global disease data, and we can look at trends and transitions and what's happening and what's changing. And this was important because we discovered that chronic illness and non-communicable diseases were far worse than we had anticipated. A lot of the first 15 years of the millennium and a lot of the Millennium Development Goals had a strong focus on infectious disease because, again, from this initial global burden of disease study, they were highly prominent, especially in the lowest income nations. This second, only 20 years later, only 20 years. Think of global history. 20 years is a blip. And only in that time did we recognize that non-communicable diseases were a global issue and were rising at unprecedented rates, including in the lowest, middle, and high-income countries. And we had missed that. So another UN summit took place in 2011, focused specifically on non-communicable diseases worldwide, dispelling the myth that infectious disease is a challenge in lower-income countries and chronic and non-communicable diseases are for high-income countries. We know that's not true. In fact, the majority of non-communicable diseases are in low and middle-income countries, including oral diseases. And why is 2011 one of my favorite highlights? Because there was a side session on oral health at this UN summit, and for the first time, is anyone counting? How many times have I said first? A bunch. You've lost count, right? For the first time, the UN formally recognized in a UN declaration that oral diseases are a major global problem. We are important. We are so important. Our workforce is one of the most needed and has the most potential to make change and really make an impact. Now, today, we're in the Sustainable Development era. So the MDG era ended in 2015, and a new set of goals were developed with a continued focus on health and sustainability. And we've had another side session on oral health since then. So again, This may seem unremarkable and kind of like just a historic timeline, but each of these hash marks is incredibly significant for our profession and for our students, and I feel everyone going into the dental profession needs to understand how important they are and why. So what does this mean for me? So this is where, as Dr. Greenspan said, we decided to really take a look at how we are training the next generation, the future. How do we adjust to all these firsts that I just mentioned when social determinants of health, aging and geriatric populations, Millennium Development Goals, global health were never part of my lexicon as a dental student? And that wasn't that long ago. So how do we change this and make these adjustments? And so we're developing a curriculum model that we're calling the Global Health Learning Helix. And the idea stems from a spiral curriculum, which came out in the 60s. And that really emphasizes that concepts spiral throughout the curriculum and build on one another. And students they encounter information more than once and in more complex ways as they learn. The reason that we call it the Helix is we're looking at tying multiple learning modalities together, and I'll explain that in a bit. Now I'm going to show you some data. I don't want you to get too tied up on the graphs, but this is really just a visual to demonstrate that we are doing some data collection and some monitoring of our education innovations. But the take-home message here is that in 2011, with Dr. Calendarian, my former chair, and our department and our Office of Global Health, we took what was happening with John Greenspan and my dean, Bruce Donoff, and turned this into a course. To our knowledge, it was one of the first, if not the first, formal global health courses in a U.S. dental school. And this course was required for our dental public health residents and our general, our GPR, thank you, our general practice residents, and an elective for the other specialties. And so these bars basically demonstrate that the first year we launched the course, we did kind of a pre-knowledge assessment on some major themes, some of which I talked about on that timeline, many that we were discussing within our global oral health interest group. Some of these themes include the global burden of disease, global populations, trends and transitions, including the nutrition transition, a look at primary care and its importance in prevention and health promotion, etc. So we did a pre-assessment and we did a post-assessment. So the middle bar is the post, and clearly you see a difference, right? So, some of the early results demonstrate that students reported they felt their knowledge in these topics increased. And then 5 years later, we did a follow-up and we sent out a survey to all students who had taken the course over the 5 years and asked them again, how do you feel about your knowledge about these topics? And interestingly, their self-reported knowledge remained relatively steady, and partly because they reported that what they learned in that course, they are using in their careers today or in their residency programs. Interprofessional relationships, working with communities, extending their skill sets beyond clinical care, looking at prevention and policy and learning how to write grants and how to work with governments. So they were actually working on applying in their careers the things that we had talked about in the classroom, and that had helped with their knowledge retention over those 5 years. So we were pleased with those results. Around the same time, Dr. Greenspan and the Global Oral Health Interest Group were leading an effort on really starting to develop a set of competencies around global oral health. And our group published the first Global Oral Health Competency Matrix, which is when we started to really say, there's a formal framework to guide people developing programs and educational training. There are all kinds of disciplines that are represented in this matrix. So dentists, dental students are some of those, but non-oral health providers and non-health people are also included in these global oral health competencies. So we teased out for our next step of our education program competencies that we felt applied to dental students and dental education today, and took a deeper dive into looking at what does global health, competency-based global health education look like for dentistry. And that became the precursor of what we were calling the Global Health Starter Kit, so version 1.0. And really what that is we started to look at our course materials and apply these competencies, and we wanted to turn this into an educational product for others to start using. And so we worked very closely with the Global Oral Health Interest Group and created this open access curriculum based on our 5 years of work and the data that we had collected through our own curriculum. And it consists of 5 modules, and each module has a theme. These are going to sound familiar. These themes are related to the themes that we had been assessing in our own curriculum and that we had been working on with the Global Oral Health Interest Group. We also invited 13 authors, an interdisciplinary mix of authors, both within and outside the U.S. So module 1 is global trends, and there are related competencies that module is built on. Module 2 is global goals, same thing, related competencies. Module 3, back to basics, primary care, and it really looks at how do we need to rethink about health systems, especially as the disease burden changes and the age of people seeking healthcare, and especially chronic healthcare, how that shifts, and the important role that primary care plays, including considering oral health care as part of primary care. Module 4, social determinants and risks. Part of the reason we're seeing these changes in the world is because of evolving risk factors. With urbanization comes increasing access to risk factors for non-communicable and oral diseases like tobacco, alcohol, and sugar, for example. But those aren't even limited to urban areas anymore. Really, they're pervasive. Module 5, ethics and sustainability. So as we start to consider developing programs and responding to these tremendous global challenges, how do we maintain a strong focus on partnership and ethical engagement as often outsiders in the areas where we're working? And especially, how do we ensure sustainability of our efforts along the way? So what we did was, in 2018, last year, when I taught my course again that spring for our residents, I got rid of all my previous course materials, and I taught this starter kit, the kit that we intended to release to the world for people to use, because I really wanted to be able to say, this is classroom tested. I taught this. I wanted to feel like I could stand behind this work. So we got rid of our course materials. We taught the starter kit as it is, as we created it. And these bars are basically saying that the starter kit performed as well, if not better, than our previous course materials, which is what you would hope. We'd at least want it to measure up, but in many cases it did better. Our students reported stronger outcomes. So what we did next was we actually started a global health for our pre-doc students, our DMD students. So now all of our second-year dental students get this course as well. Part of why we were able to do that is because we had been collecting regular data and regular feedback, and the course had gone well. So when an opportunity to create something new in our curriculum opened, our course was one of the first to be offered time in the core curriculum. So now all our DMD students take this course. This slide says the same thing. So in 2017, when I started the global health course, I taught my usual materials, and then I did the same thing in 2018. I threw out all those materials and taught the global health starter kit, and we had the same outcomes with our pre-doc students. They did just as well with the starter kit materials, if not better, than with our previous course materials. So we felt that, you know what, this Global Health Starter Kit seems to be working for us. We're getting good feedback, and now we can release it to the world. And so in December of 2018, it went live. I felt like I can relate to Ben. I had a baby. I felt like I had been working on this project day, night, weekends, with such a wonderful team of authors and contributors, and testing it again. We did website testing where we sent it out to a lot of our interest group and collaborators to see how the website works for them, and took that back. All our modules were peer reviewed, and by December we felt it was ready. And so this is it. There's me. If you went to dinner with me last night, I'm realizing I was wearing the same sweater. So I think I need to go shopping. I know. And I'm pretty sure I'm wearing this in one of the other modules. So I need to build out my wardrobe. So this is what you'll see now. So you can find this if you Google Global Health Starter Kit, or if you go to the HSDM website. This is where all the materials are hosted. They're all free and open and accessible for anyone in the world. That was one of our core values, is to make this free for everybody. And so it includes presentations, teaching notes, recommended readings, matrices for assessing your students. Basically, we wanted it to be a classroom-ready starter kit. We call it a starter kit because everyone's going to use it differently and need to adapt it for their own needs. So it's really to get you started, but ideally provide you with everything you need to get started if this is something you want to implement within your own curriculum. We ended up getting matching funding, which was wonderful. And so with that additional funding, we created a second version, and this is for learners. So the first version is for educators to implement in their curriculum. The second version is for learners who either don't have a faculty champion that's trying to integrate this into their programs, or they just want to learn more and take this, learn these materials on their own. So the learner version has all the same materials, but geared towards students. And so they can actually view me teaching with a nice green screen professional background, and I'll teach each module in video format, and there are recommended readings, so students can go through these on their own if they choose. So having both versions has really allowed for optimal flexibility. And we're very excited that since December, since the launch of the materials, our videos have been viewed and downloaded over 500 times already. So the momentum is exciting, and we're really delighted by the response. But this was not the ending point for us, and it was not the intentional ending point for anyone who wants to use the starter kit, because as we all know, an experience is worth 1,000 lectures. I consider global health no different than clinical dentistry. You cannot learn how to prepare and restore a cavity in a classroom. The classroom is where we introduce the foundation, why we cut a prep the way we do, why we use the burr for this prep versus that. That happens in the classroom. But really, to apply that, students have to practice. And global health is no different. And this is really where we've developed the Global Health Starter, or the Global Health Learning Helix. So this didactic work, the starter kit, is the foundation, and that can take place in the classroom. But tied to that foundation of knowledge is a field-based practical learning experience. And so for us, we developed a course in Costa Rica with partners who very much aligned with this knowledge foundation, and who could provide a field-based practical extension of what our students learned in the classroom. And so this classroom learning and field-based learning spiral together and help our students tie these experiences together through common shared competencies. So those competencies are taught in both the classroom and the field, so students can apply what they're learning in real time. Another fancy graph, the take home here is we've just started piloting this field-based course in Costa Rica. And so this graph basically shows that we assessed the outcomes of our students both before and after the didactic course. And then we had 3 students who took the field-based course as an elective, and those 3 students had significantly better knowledge retention 6 months later than the students who didn't take the field-based course. And to all of us, that kind of sounds like a no-brainer. You know, of course, if you learn something in a classroom and then see it in real life, it's going to stick with you. But when it comes to funding and sustaining a curricular innovation, you've got to have the data behind it. And so we're tracking that to really demonstrate if it's true that students who have a field-based experience really are able to apply these competencies and retain the knowledge that they're gaining. So now I'm going to take you along with my students to Costa Rica, and you can hear from them how they felt after going through this Global Health Learning Helix experience.
This is an exciting program for us. It's a combination of students from Harvard Dental and from the University of Costa Rica from the School of Dentistry. Now, they are here for a 1-week extension course, building on a program that they have been taking.
Part of a project that we're calling the Global Health Learning Helix, which basically you imagine two threads of learning, one that takes place in a classroom and one that takes place in the world. The backbone of the Helix are competencies or objectives that we are striving to meet both through classroom learning and field-based learning. Professional collaboration is one of those backbones. Team-based learning and problem solving is another backbone. Focus on prevention and health promotion is one of the other backbones. We're evaluating and piloting a lot of this as a team with CISG to see how this model works, where we are learning together in a classroom setting in a totally different region of the world, but tackling common challenges and then bringing our learning to a new setting and seeing where the synergies are possible.
So let's say today we were visiting the Kansona indigenous territory, where we've worked closely with both traditional birth attendants and traditional healers in order to provide better channels of communication between the traditional health system and the Western health system. So that's just one example of what the students do and how they combine the in-class learning with the experiential learning.
I gain an appreciation for the importance of forming connections with communities and building these relationships that can have health impacts that are far superior to just going into a community and providing care, whether it's dentistry, medicine, surgery. Forming a sustainable relationship with community where you can facilitate autonomy is really something that I took away from this course.
One of our core values is really whole patient health and seeing the mouth as part of the body. So our students learn from the moment they begin that the mouth belongs in the body. I think Costa Rica is a really exciting example of that in practice, where patients are seen and treated holistically, and oral health is included from the primary care level all the way into their hospital care.
I had never learned about Costa Rica's healthcare system. I had heard from looking into this course that it was very well planned and developed, but other than that, didn't know anything about it. And I think seeing how their approach to a smaller country has been seemingly very successful, and how much trust and value people in this country actually place in their healthcare system and their government, I think that surprised me coming from the US, where I've lived my entire life, and most people will question me constantly as a healthcare provider one day, and I think it was both encouraging and truly surprising.
The potential takeaways from this week for our students at HSDM, I think, are numerous. It depends, I think, where they are in their thinking around their role as a dentist in today's world, but my hope is that they really think about how to optimize the skills and knowledge they're gaining at HSDM in ways they maybe haven't even considered. Or if they have considered, that's really begin to clarify, the direction they may want to go with their careers in the short term, in the long term, so that they can really feel like they're contributing and meeting their full potential as dentists.
I really learned how collaborative global health is. Global health is not done in a vacuum. It's not one person that can improve global health and work on global health alone. It's all collaborative, and connecting with the University of Costa Rica dental students, that we both learn so much from each other, and we'll be future colleagues in global health as well. That's the biggest takeaway I've had about global health through this course. I didn't realize how immersive the experience would be, between living in this jungle environment for a week to entering indigenous communities and interacting with the community leaders and going into someone's home and seeing what their life was like, to visiting an African palm oil plantation, to talking with somebody in the Ministry of Health. There were just so many factors that I didn't realize would enrich the experience. I'm just incredibly appreciative of this experience. It's definitely far exceeded my expectations. I've learned so much. I've made so many awesome connections with people.
This week just really bolstered my toolbox of questions to ask or perspectives to think about, so that wherever and whatever I end up doing, I think it gave me a greater sense of humility as well as tools to use down the road to hopefully make an impact wherever I am, and use my dental career to serve others.
So there's a lot here, but this is to demonstrate what we're calling our early adopters. So if you're familiar with an innovation curve, there's kind of the point of the curve where the innovation is developed. Then you've got the early adopters. So like me, in line for the first iPhone in 2007, I was an early adopter of that innovation. And so this demonstrates that we're very excited to have a set of early adopters of this curriculum model and of the Global Health Starter Kit. So we've got 3 universities who are formally adopting this in various ways into their pre-doctoral curriculum. And then we have 2 outside of the U.S. in lower and middle income countries adopting this. And then another pleasant surprise was we've been contacted by a number of NGOs and private dentists who want to have access to the materials and utilize those to bolster their own community projects or programs or their own NGOs. So we're really excited so far with the progress and interest, and I just think that goes to show how thirsty people are for this information. And it's that whole, we do the best we can until we know better. And once we know better, we must do better. So let's revisit this question. In a globalizing world, what is the role of the dental profession today? And then my additional question is, how can we as dental educators be responsive to today's demands in a globalizing world? Remember with my story, I said I'd tie it up at the end. So this is the second piece of that story. It's called Bridges. A famous story begins, there are 2 doctors walking along a riverbank, and they see an injured man floating down the river. They pull him to safety and bandage his wounds. He thanks them and walks on. Then they see an injured woman floating down the river, so they pull her to safety and bandage her wounds too. Over and over, they pull men, women, and children from the river to bandage their wounds. Finally, one of the doctors walks upstream and sees that people are getting injured falling into the river trying to cross it. Trying to cross it. And this doctor says, instead of placing bandages, I'm going to build a bridge, and people no longer fell into the river trying to cross it. This is what I do. I build bridges, and I teach my students how to build them too. I haven't treated a patient in many years. My job is to prevent disease and promote health by building bridges instead, so people won't need bandages. I build bridges between cultures, between programs that don't have dental care and those that do, between communities who need training to provide oral care and trainers who can teach them. I work where dentistry isn't and build a bridge to bring it there permanently. We will always need doctors who can place bandages, but we need more doctors who are willing to devote their lives and their careers to building bridges and create long-term solutions rather than Band-Aid fixes. We don't have enough Band-Aids. Millions of children and families around the world will never receive the care they need. It is an honor and a privilege to build and cross bridges every day around the world. And in January, when my daughter joined me in Costa Rica, I bridged my personal and professional life as I watched my daughter cross what I hope will be the first of many bridges in her lifetime too. With that, I thank you very much.
Thank you, Dr. Seymour, for a wonderful presentation and sharing with us this great resource that you've developed with your collaborators, and what a wonderful opportunity your dental students have to be able to go to Costa Rica. We have some time for a few questions.
So just share with us where you've taken this thus far internationally. You showed us Costa Rica. Have you done that elsewhere, or are other people doing it?
Thank you. So if I understand the question, then where is the classroom learning and the field learning taking place? So for us, as you saw, it took us several years to develop and refine a didactic curriculum that we felt confident in and that really met the competencies. And so for us, our next step is developing a field experience, and Costa Rica is our first. We've piloted that twice. So we are deliberate and selective in the field experiences we're building for our students so that we can really maintain that quality of the curriculum that we've worked so hard to build. So for us, Costa Rica is the first. Our students do engage in a number of countries through other methods, so through mentored scholarly projects and research, etc. Our partners, our early adopters, all had, for the most part, pre-existing field experiences that ranged. Some of them, it was more, as you mentioned, the kind of helicopter model where they take their students for spring break and pull teeth and then come back. And others were very robust long-term research program for their students. But they all had this interest and need in providing more of an educational framework around those field experiences, so they're kind of retrofitting their field experiences. So we're seeing this tied to field experiences in many, many different countries, just depending on which programs are picking them up. Does that answer the question? Thank you.
I had a question. You listed you had a list of competencies. How do you assess your students that they're meeting these competencies?
I'm so glad you asked. So we have assessment guides or metrics, recommended metrics for each of our modules. That you want me to? Oh, you want me to stand up? Oh no. Okay. Thanks. So with each of our modules is an assessment guide, and we developed some example assessment multiple choice questions that can be used, but assessments need to specifically be catered to the way something is taught and the setting. And so the guide is to provide support for people who are using the materials in ways we might not know about. So they may not teach the materials the same way or in the same order as we do, so we can't write assessments for them. So we have assessment guides where we kind of have a baseline. So your students should, at a baseline, meet X, Y, Z, and then they can create an assessment that's customized to how they're using the materials, which could be essay, multiple choice, verbal exam, anything. I do a lot of qualitative assessment right now, and we also do multiple choice assessments.
So how did you pick Costa Rica? Costa Rica has a highly developed health structure. The internet works. You can drink the water. You can drive. Their dental students, my understanding, have to do 2 years of social service in the small towns. So to me, it's an excellent model for how to do prevention and oral health, but it's very highly developed. And I wonder why you picked Costa Rica compared to some of the other countries that are in dire need.
Great question. I would argue dire need exists everywhere, and so we don't focus on geography or location as much as the quality of the experience, the partnership, and an existing framework that aligns with our curriculum. So Costa Rica has the Inter-American Center for Global Health, which is very focused on high-quality, competency-based global health education. So they were a very natural fit for us as far as providing the educational framework, extending from our own curriculum into a field site. That being said, the indigenous territory is anything but developed. No electricity, no running water, and our partners helped to build a sustainable healthcare system within that indigenous territory from the ground up, including government buy-in and government support. And a lot of the community members in Cote de Bruce are not recognized as citizens of Costa Rica and still receive government benefits. So we felt that was an important example of how successful community partnerships can shift health outcomes for our students. Thanks.
Okay, thank you, Dr. Seymour. We'll have another opportunity during the panel discussion to ask more questions. So at this time, I'd like to call up Dr. Susan Hyde.
Good afternoon. It is my honor to introduce Dr. Srisilapanan. I met Pat in 2016 at the FDI World Dental Federation's Oral Health and Aging Population Workshop, which was held in Lucerne, Switzerland. Now, Lucerne, Switzerland is a really ideal place for a conference. And my late husband and I had the pleasure of sharing several memorable meals with Pat, her husband, and her son. In addition to her dental degree, Dr. Srisilapanan has earned her master's in preventive medicine and environmental health, her doctorate in dental public health. She has been a faculty member at the Chiang Mai University for 28 years, taking on many leadership roles such as department head of community dentistry and associate dean positions for community services, for international relations and special affairs, and for the graduate school. When Dr. Srisilapanan decided to retire last year, she took on the role of dean for the dental school at Nation University. Now, I don't know about you, but that level of leadership and dedication and hard work is not part of my retirement plans. Dr. Srisilapanan continues to publish widely, and she is a highly regarded international speaker. I think she's given invited presentations on every continent except Antarctica, and there's still plenty of time for that to happen. Today, she shares with us about the dental health in Thailand and its relationship to global health. Dr. Srisilapanan, on behalf of UCSF, welcome to San Francisco.
Sawadee. So Susan demonstrate to you this is the way we say greeting in Thailand. So good afternoon, all honored guests. It is my great honor and pleasure to be invited to speak at this symposium. And as you know, I'm from Thailand, another half of the world. And I hope that my presentation today will give you some insight into the dental public health as well as care for older people in my country. My contents will cover, firstly, Thailand at a glance to give you overview of Thailand and the public and dental public health system. National Oral Health Survey might be your first module. And I think that's why Ben asked me to put this, in like example after your presentation. And lastly will be oral health for older people. Okay, Sawadee. And before I start my presentation, and this is part of my work, and I have been working also collaborative with Colgate-Palmolive Dental Health Unit for more than 15 years with the University of Manchester, which gives me a lot of opportunity to travel. This is part of my life, and we just celebrate the 50th anniversary for the relationship between academia and industry, which is very innovative way of working together. That was in Manchester last year. And also where I met with Susan, that was nice place to have workshop. You get boring, you get out, you see the mountain and the lake. And that was the FBI expert conference for oral health for aging populations. Yeah, that's where I meet Susan. And where my sons ate 2 of her steaks. And the outcome of that workshops, the conference was published in the International Dental Journal, October 2017. If any of you interested, you can take a look at that publication. And beside that, I have a good friend from Japan, Professor Hiroshi Ogawa, and he's at WHO headquarters in Geneva, and we have been discussed a lot, and he has been helping me to give some comments in some of the symposium regarding developing countries. Because sometimes when you go to a lot of meetings and people talk about, developed country, so he's the one who really good mentor for me. Also, I've been to the senior dental leaders and give me opportunity to meet among other leaders around the world, which was another good opportunity in 2015 with the big storm in Boston, snowstorm. And lately, I was invited to speak at the Cambodian Dental Association in 2016. And, it gave me opportunity to learn that they are so young. all the dentists in Cambodia are so young. And, geriatric dentistry is not that much interest there. So I feel, my lecture is not that interest compared with the other lecturer. That was my first impression. And also I organized the Oral Health and Oral Care and Quality of Life lecture at the International Association for Gerontology and Geriatric Medicine. It's where dentistry, have a session in the big gerontology meeting. And I have an opportunity to join Professor Ronan Attingers, who is very famous from Iowa, to speak on that meeting. Also, with my I share 2 foundations, which could be a part that I could organize, similar to Brittany do for students. At Chairperson of Foundation for Older Person Development, we do a lot of projects for old people in Chiang Mai and Thailand as a whole. And we have a lot of internship, PhD student, master program student come to help us during, under our foundation. And also I'm vice president of the Thai Society for Gerontology and Geriatric Medicines. So we have a good opportunity during that last year to meet with the Minister of Public Health. He's a medical doctor, used to be academics before, about manpower in geriatric, which is becoming, we need a lot of manpower who understanding about geriatric issues. So it's a good opportunity to do the policy level. And beside that, I'm a chairperson of another foundation, Northern Women Development Foundation, where we got funding to do the cleft palate project in Thailand, Laos, and Myanmar since 2004. So we finished operation at least 500 patients. And not only operation, we do rehabilitation, we do speech therapist, we do nutrition, and follow up. And right now we expand our projects a lot in Myanmar and in Laos. So we're training the local people to be able to do everything themselves, not like, helicopter types. You fly there, you do operation, and then you leave. But this is another good project that I have been doing and get the funding from Transforming Faces in Canada. And when I was young, like some of you here, I have a dream to work internationally. So my first job was working with refugees at the border. The first one is the refugee camp near Laos border, where I'm teaching young refugees children to brushing, and also working at the Cambodian border. At that time, surround my country is communist time where they have a lot of fighting. That was my first, experiencing working for other people, and I choose public health, dental public health as my specialty after that. So after that year, I went to Iowa for my dental public health skills, and until now. Now, more beautiful things, and I would like to bring you to Thailand. This is a part of the government policy.
Open your eyes to shades like no other.
The shades that open my heart. To exotic traditions.
I see new horizons. To new interpretations.
Will I get lost as I discover?
When exploring the world that opens up new shades around me, I feel great in every moment. When I see the world around me,
every corner makes your imagination wander.
Once arrived, you feel reawakened.
You're making contact with your new self. It's open and challenging.
I'm embracing the earth around me.
It's open and inviting to be in the middle of nowhere.
Or in the center of it all. Their hearts will open yours. Amazing things are in all directions. Its millions of shades wait at every turn. What else can you do but to venture further? Because the new shades are waiting. Open to the new shades. Amazing Thailand.
So you like to go? So I do marketing. Do marketing for the internship for anyone who would like to do volunteers and part of global interesting in dental public health. So now we come to the facts and figures. So Thailand, you understand us more. We have 69 million people. Life expectancy at birth is 75 years. The number of dentists is 12,000, around that. And dentists per population ratio is 1 to 5,686. However, in the rural area, it could be like more or less until 1 to 16,000 or 12,000. And we have dental nurse. The number of dental nurse in Thailand, they have 2 years training in the past, and now it's 4-year training. And they can do some simple treatment for children under 12 years old. Simple extraction, simple fillings. And the number of dental nurse is 7,300, around that. And dental nurse per population ratio is 1 to 8,500. And now I will explain to you about the public and dental public health system. In Thailand, the district health system is the backbone of our public health system because 80% of our people live in the rural area. And, we have 2 things. One is the district hospital or community hospital. Another one we call health promoting hospital or health center. I would like to start with the health center or health promoting hospitals. This is the very smallest part for taking care of primary care in Thailand. The staff could be a team of 3 to 5 nurses or paramedics. Some places can have dental nurse, but not everywhere. Every hospital have dental nurse. And a dentist might visit there once a week or once a month. It depends on the location. This is one of the health promoting hospital where they don't have dental nurse, don't have dentists, but I have opportunity to work with them for 20 years. For district hospital or community hospital, here you can have 3 to 4 general practitioners, 2 or 3 pharmacists, 1 to 2 dental nurses, and more than 20 paramedics. It can have 30 to 150 beds and cover 30,000 to 50,000 people. And the dentist population can be 1 to 12,000 or less, depend on the area. And higher or specialty, we have regional hospital, general hospital, as well as university hospital. And this one, this one is the one in Chiang Mai. Next to my dental school is walking distance, and the low one is in Bangkok. And this is also private hospital is very popular in Thailand as well, and it's rapid growth of private hospital and private clinic, especially dental clinic. And in summary, the health system, from the bottom, health promoting hospital and health center, we have almost 10,000, spread it all over every small sub-district level. For the district, we have community hospital, 780 of them. And, below above that, we have regional and general hospitals, about 116. And beside that, we have university hospital, military hospital, and private hospital and private clinic, complements all the system. About financing system, it's quite different from here. A lot of questions asking me about, you have insurance, dental insurance. But in Thailand, we have 3 main health insurance schemes. The first one we call Civil Servant Medical Benefit Scheme. Second one is Social Health Insurance. The third one is Universal Coverage System, UC. And the first one, the Civil Service Medical Benefit Scheme, cover government employees and their spouses. I'm under that scheme, okay? And also pensioners will be under that scheme. And coverage is about 4.4 million people. And outpatients have to pay fee for service, and you can reimburse. For social health insurance, cover most of the private sector employees, about 10.6 million. The big one, the majority one is UC, universal coverage, and cover the others not covered by the first two. It's covered about 48 million. So universal coverage system, if you're interested, you can look at all the paper. It's one of the most good model for developing countries, for Thailand. After we have very good medical doctors who work in public health, devoted themselves into changing all the system. So for us, we feel that all the people in Thailand is covered by some type of health providers. So this is one of the good things for our system. For example of the oral health care in each schemes, for example, civil servant medical benefits is the best one to cover most of the oral care. You can get free extraction, dental fillings, endodontic treatment with some limited upper limit reimbursement. Even fixed prosthodontic, you get some pay. Scaling, free. Plastic-based dentures, all free. And dental examination. But social health insurance, you get some part of it. You get certain amount of payment per year. This is the smallest benefit scheme. And the UC, and under the universal coverage scheme, you can have extraction, dental fillings, scaling, plastic-based dentures, and dental examination. So different scheme, give different dental care. However, for me, I think we have quite a good system in terms of oral care, especially prevention and promotion. You see that for prevention and promotion, we set up the policy to have minimum oral health care in the public health system that children under 12 years of age, people 60 and over, people with disabilities, they are eligible for free for oral health promotion, prevention, dental examination, and simple dental treatment. Now, I would like to give you some pictures from our last National Oral Health Survey to see what is the dental problems, what is the situation of oral health in Thailand in different age group. Normally in the National Health Survey, you first examine the 5 years old. However, in developing country like Thailand, early childhood caries. It's very important and increase rapidly. So we include the 3 years old in our oral health examination. So the carie-free is not that good. When you born 3 years, half of the population, half of the 3 years old children have dental decay. They are so young. I think it's the disease of the mother who put something into the children's mouth. And then after you come to 5 years, it's even worse. About 80% have dental decays, right? For 12 years, when you have permanent teeth, again, half of them have dental caries. The prevalence of dental caries is quite high. However, the mean DMFT for 12 years old is not that bad, so it's 1.4. For adult, we have quite good, number of functional teeth, 28 in the mean. And we start to have periodontitis, about 30%, almost 30% start to having periodontal disease. And when it comes to the old people, functional teeth is quite good, 18 teeth per person. Periodontal disease increasing. Edentulousness is very low, which is quite good. And then we add 80 years old group into our national survey as well. And we see that, the condition is not that bad. So I would like to compare to you the trends from our first, from the one in 1984 until the last one 2 years ago. And you see the trends for 5 years old is a little bit better. After the country have put a lot of efforts on prevention and promotion. Dental nurses have the compulsory job to put fluoride varnish for the 3-year-old children. So we can keep 5 years old a little bit better. For 12 years old, the trend for the FT is quite stable, which is very good. And 15 years old is quite good, along the 8 years, 7 years. 60 years old is also, we have more than 50% of the old people who have more than 20 to have functional teeth, more than 20 teeth to function. This is the trend of the whole country. However, when you look at the comparison between urban and rural, this is the study, I do with my professor sitting back there in this room, Professor Jeffrey Roseman, who's from Alabama, and he suggests to me that we should look at the comparison between urban and rural and look at the trends over time for dental caries. So looking at the urban and rural, you can see that after 1999, before that, rural is, the 3 years old, the rural always higher. But for the 5 years old, the rural has been lower. However, since 1999, the percentage of caries prevalence in the rural area is higher and higher compared to urban area. This is something that we need to, have to concentrate on in my country. And also 12 years old, similar. And this is the whole picture of the oral health status in Thailand. So I hope you understand a little bit about our problem, okay? However, my expertise is on oral health for older people and have been working on this area for more than 20 years. So the next session will be oral health for older people. Before that, I would like to give you some picture of our demographic situation as well as our national oral health policy. The Thai population, we have 69 million, right? 11.3 are old people. In Thailand, only 60 and above we consider senior. So actually, I may be young here, not retired. If I'm in Thailand, I'm retired earlier. So now it's about 17% of the population is, called old people. And the trend is, rising. And Thailand has entered aging society where 10% of the people are above 60. That's starting from 2005. See, we start to be aging society since 2005, where more than 10% is 60 and over. In the next 2 years, we're going to have older people more than 20%, which call complete age society. In the next 12 years, I think, we will have older people more than 28%. 1 in 3 people will be senior, and we call super age society. Similar to Japan, similar to Western country, we said in our back home that we're aging before we get rich. And we never get rich because there's a lot of aging people and nobody work and send the tax. So this is the main problem we have been fighting for many years. We have to rapidly doing something because you cannot wait. And suddenly, in 10 years, everybody will be aging, and I hope I still have energy to do some work. And this is the problem of Thailand, and this is not good for the whole world. If another half of the world aging as well, and it's not ready, no money, this is the problem. So the problem is that the speed of aging is very fast. Like in Europe, you take like 60 years or even 100 years for like France to become aging society. Thailand take only 26 years. It's not that long at all. I started 20 years ago, and now still problem. We still could not go that far, and the number of older people will increase in the whole country, and also we'll be more dependent on older people. And you, in Western country, you have that some years ago. But for us, we enjoy having healthy people for so long. And suddenly, those people will become dependent. Who's going to take care? One good part of Thailand is that the government have the policy not building nursing home. No nursing home. No public nursing home anymore. The one existed, like in Chiang Mai, only one. I think the whole country we have only 5 or 6. And how can we going to do if we have more dependent, people? So that's the thing that we have to, build up the policy and work a lot for our aging society. And, when we have more dependent older people, caregiver will be decreased because young people we have less young people and nobody really want to do this job compared to babysitter or, nursery. They prefer to do another thing. So this is the problem that we have to confront. Therefore, there's a policy from the MOPH's Ministry of Public Health to strengthen the primary care at the sub-district level. Therefore, sub-district health, so health promoting hospital, and local authority, it means local government, have to join together and take care of the old people in their own area. All the money will be sent to the local government, and they and the Ministry of Public Health people have to decide how to taking care of your own people. And old people from healthy until dependent. Okay, so both of them, sub-district healthcare provider and local authorities, share responsibilities to provide good quality of care to older people. Besides that, we have 2 more policies. For Thailand, we just have the National Oral Health Policy for Older People, 2015-2022. Luckily, we have been able to push that policy, passing the government, have a bill and, get funding. 3 main objectives is to improve quality of oral care for older people at all healthcare levels. Capacity building in oral care for older people, for oral health professionals. So we have the funding for public health people, dental public health people who work in the community hospital. Go back for the master program for free scholarship. Okay. We got scholarship for them for short course training, 4 months training in prosthodontics, periodontology, and oral medicines. We give them scholarship for dental nurse to have short course in geriatric dentistry. So this is part of the capacity building for oral care for dental professions. And also research development in geriatric dentistry. Another policy is the long-term care at sub-district level. So the government encourage the capacity building for oral care in long-term care for dependent older people. I will give you some picture later. Okay. Now, for independent older people, healthy aging group. Now it's a nice group to work with. We have enjoyed that group for many years. Thailand working through senior club activity. Each small sub-district develop their own senior clubs. So most of them will join like members for free, and local authorities as well as the health promoting hospital will, do some activities for them. For example, so I've been invited to teach them, some of the oral care, and I work them in groups, to brushing after lunch, and something like that for aging, healthy aging group. And also, this is very new in Thailand. So local authorities, follow that policy. So every health promoting hospital joining with the local authorities, they start to have school for older people in each setting. It's only once a month, only one day. But give opportunity for older people to go back to school. Because the older people in Thailand, in rural area, some of them never have opportunity to go to school, regular school. So when they can go to school, they decide that they would like to wear uniform. So this is what they want to go, like school bus. They want to go to a trip. They want to have school lunch. So it's quite, firstly, I think, oh really? And after a while, it's been very successful with, sharing on social medias. So it seems like it's a request from old people that they want this and that. And for me, I've been invited to give a speak for oral care. They invite nurse. It's like school. The whole day, you ask health professional, you talk about saving monies, you talk about how to talk with your kids, you learn about IT, using computer. It's a lot of things that interesting for them. They can request, and officers will invite speaker to them. So this is very successful so far. This just started 2 years ago, and for me, I feel that okay. And last time that I give a lecture, it include people with disability as well. So they come out of the house. It's help them to extend healthy years. Now I would like to take you to some of the activities at the Health Promoting Hospital. Remember this place where I worked for 20 years? They have a wide bridge, it's very famous, where the train from the south, if they want to go to Chiang Mai in the north, they have to cross to this bridge. However, now surrounded this bridge is the famous golf course. So if you want to join me to learn about primary care at this health promoting hospital, you bring your golf club, okay? I just take my friends there, and they have a good hotel. I always said, okay, you can learn primary care. Now I do the oral health survey for the whole village. It takes me 1 year, almost finished. And this is my staff. Firstly, I think you can stay at that hotel overnight, play golf, and then you do oral examination, and in the afternoon you play golf again. And it's a very nice area. And on the top, where we have meeting room, this is the view from our meeting room. So I really like this place. Okay, in this place, I have 4 friends. We have 2 public health officers. We have 2 registered nurses. And the nurse have master degree. They have postgraduate training. For the nurse, they're more competitive. There's a lot of nurses, right? They go on for higher education. But for dental profession, we're still a little bit behind nurse. Actually, the 2 ladies, even though they call public health officer, their background is dental nurse. The problem with dental nurse in Thailand is that the career path in the past is not so good because they have only 2 years education. If they want to go on to have bachelor, they have to go to school for public health officers. It's not school for dental nurse. And then they have to change their position, career into public health officer. So we lost them. So only 36% of the dental nurse still working in the public system. However, these 2 with the dental nurse background, when I talk about oral health, it's bring their life back into dentistry. They are more enthusiastic and they understand a lot, and they would like to start oral activities, oral care for old people in their own area. So in this place, they're taking care of about 3,700 people, where 25% super age society already in this village. In the north, we have the highest proportion of old people. And they start to have only 24 homebound. Bedbound, people stay in beds very small, but increasing very rapidly in Thailand. So nurse per population is only 1 to 1,800. No dentist, no real dental nurse who will come to do dental work. And luckily, we have 1 dental nurse from a community hospital, about half an hour away, come once a week to provide oral health examination. And we have 109 people called village health volunteer. These are people who are people in the village who volunteer to help public health workers to do some simple work like blood pressure, home visits, follow up with the babies, etc. And they work to cover 7 villages. I will give you some more picture. So this is the time where only one of our village health volunteer will visit a stroke patients about oral care. So they met in the temple, and then they start to go to the home of the patients by motorcycle. And this is the village health volunteer, and this is the health officers. I go in my car. And she just recovered from stroke. And they would like to give some oral health advice and to assess how she can brush her teeth, any help is needed. And that's when, we all going to her house. And this is very common for village health volunteer to go to the home visit. So each of them will take care of around 10 homes, and they know each other well. And it's good to monitor what happened physically, mentally, psychologically, like have friends come to the house almost every day, or walking past and then they shout to each other, And some advice given. And also lately, with the new policy, there's a lot of need for the training for village health volunteer about oral health for older people, because village health volunteer, they have very limited education background. So we need to give them, some, especially why oral health is important for old people. This is my main objective of training. So we start to have the training activities. I received the funding from the Thai Health Foundation, and I give the money for the people in the community hospital to organize the training activity. This is the dentist. Okay. Her background is very interesting. She has her PhD from North Carolina in oral biology. And then she is placed in the community hospital. And she knows nothing about public health. And she come to me, I have the policy. The government have the policy about oral health for village health volunteer and my people. What should I do? So she start, I give her a consultant, and she joined my project on training the oral care for dependent older people. So she has done very well, setting up the training, for, simulation, for bed bow, and this. And now she start to come back to my department for her postgraduate training in dental public health after PhD in oral biology. It's very interesting. So the young people, if you're interested in the public health, go directly. Don't waste your time. So this is her project, and I'm very impressed for her for the first time. And she could organize a very good training for them to have hand-on activities. So this is for dental health profession to do the training. And another policy lately, Thailand have the influence from Japan to organize the group called Care Manager. Care Manager and Caregiver under Ministry of Public Health have some meaning. Care Manager is a dental nurse in the health promoting hospital who is trained about geriatric gerontology. They have to take care of 10 independent older people. And under them, they have to have caregivers to help them. And these caregivers will get paid about $2 per one patient that they visit. I don't know if it's a good system or not, because normally village health volunteer will get no payment. So the government have another system under the name Care Manager and Caregiver. However, after 2 years, and working with this group of registered nurses, this is another area north of my city, and they are so enthusiastic about this project. And she, this lady, she's under my project. She's heading of the training for the caregivers and care manager. For them, they have to take care of 7,600 people. And they have 117 homebound and 12 bedbound. And It's 7 hours training course developed by the Ministry of Public Health, sending the curriculum to every health promoting hospital. So they have to train the care manager first, and also train the caregivers as a lecture, hand-on didactic, about everything's about care for older people. Dentistry or oral care is only 3 hours among 70 hours. And the important one is to go to the house for the home visit. For me, one of the things that we need to work a lot for old people is the universal design for housing. You can notice that housing in the rural area is a little bit risk for falls for older people. So we work closely with people in architect faculties to develop, a lot of renovation for housing, joining with health team. That is one of the main tasks. And here you see rehabilitation area for, stroke patient. Simple one. Even in Chiang Mai University medical department and physical therapist department, we have to go back to basic like that. You use bamboo to do some, physical therapist training that's accessible, and they can do it by themselves. They can have carpenters in the village. And this is one thing that we adapt to use in our village level. And they have a health team, consists of physician, pharmacist, physical therapist, psychiatric nurse, go to the home visit and don't have dentists. This is a problem. So we try to encourage dentists to join them. And firstly, the team said, why the dentist came? What can you do? So we need to, first make the health team understand the importance of oral health. And this is one thing that I still have to work a lot in Thailand. So therefore, one of the training I have done this last year was, training the health team. So luckily, the head nurse of the Chiang Mai University Hospital, she also received the funding from my project to organize the training for her nurse in her inpatient ward about oral health. And that was the first time for dentists to work with them in the big hospital. This is tertiary care. So for me, primary care may be easier to work with. And it's the first opportunity after 20 years to be able to, give the training in the tertiary care. So this is when I have the training oral care for the head nurse at the Chiang Mai University Hospital. And this is my postgraduate student here helping me. So after they have the training from us, she's the head nurse, they have the meeting among themselves, transfer the knowledge, and they try to, set up their schedule similar to you do in your country, to have the schedule, they have the equipment, you have monitoring, everything. But it's just started in this hospital. Besides that, I also have my own project to develop my own training curriculum for the caregivers. This is the village health volunteer on oral care. Because from 70 hours training is not enough. Only 3 hours is not enough. So I make it 3 days. So I bring village health volunteers come to the dental school, have my dental student under the curriculum, community health practice, to do the training for the village health volunteer. So we learned that you should have hand-on activity, learn about their own oral health. You need to have big medias, big pictures, okay, and one-to-one assessment and teaching. It's very good curriculum for village health volunteer. So I bring from 3 villages, and I finish, and I give them certificate, make them very proud, and then they go back, and they can do all the things that they want. So that's primary care. So not only primary care that we have, and Thailand have the policy to be the health hub, because you see we have good tourist country, right, from the video. So we have good medical service, dental service, Thai spa, massage, besides golf, and health products. And we, is a leader in Asia for health tourism. And long-term care facilities is very popular in Chiang Mai as well. And we have the big geriatric medical center in Chiang Mai, where I have the training there as well. And you see, this one is the invested with the Swiss investor. Built Vivo Bene village in Thailand with the 4-star facilities. Nearby our village hospital. And with 4-star have swimming pool that can accommodate wheelchairs, have meditation room, have gym, cooking class, Swiss restaurant. So therefore, this is the overview of our program, where it's rural, is tourism. It's a lot of policy. One policy is for local people to take care of themselves. Another policy, government want the money from medical tourism. So it's some inequality in between. However, this is my country. However, I would like to invite you that from my experience collaborating with public health workers and learning through my own experience, and I enjoy global volunteers, and I appreciate your efforts, and also later with Bethy. Global volunteer is very interesting things that if you young people and you would like to start, and I welcome all of you to Chiang Mai, Thailand.
Thank you, Dr. Srisilapanan. So we have a couple minutes for maybe one, maybe two questions before we have our break. Yes, over here. Front.
I'd like to return to the issue of the financing of dental care for the 3 segments of the Thai population. I was quite surprised to see that for 2 out of the 3 subgroups, the plans are capitated. And that for the civil servants, it's fee-for-service. I would have expected it to have been the reverse, basically because with the civil servants, I think you have a better defined population. So could you speak to that a bit? And then also, with regard to fee-for-service, is it a regulated fee structure, or is it what we have here in the United States, usual, customary, and reasonable, and blah, 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 so on and so forth? Basically, is it controlled fees?
Thank you for the question. I hope that I can explain to you. For the capitation, it means the government will provide certain amount of money per head to the hospital, right? For example, 5,000 per one population per this community hospital. If you go under UC, you can go to the hospital. And the hospital, if they give treatments and never have prevention and promotion, now they are in debt. And now most of the hospitals are in debt because everyone wants treatments, and they come, and you get capitation for the government already, you have to do the treatment. But for the first one, fee for service, they have certain amount of money, you can get it, but mostly a lot of benefit. For example, kidney dialysis has been added. For my mother, she's a pensioner. She have her heart operation. She only pay $30. Enter the operation 2 times. So it's called fee for service. It means certain fee for certain treatment under certain condition. For example, she have to be in the normal room, not fancy private room. But if you can be under that rule, you will get almost free.
Hello, thank you so much for that wonderful, very illustrative talk. I have a question about Cambodia and Thailand, and also other surrounding areas that actually most of the wealthy from Cambodia and Laos and other surrounding well, I guess mostly Cambodia and Laos. Specifically Cambodia in my part, we've done about 14 missions there, and we have one sustainable one ongoing. But I notice that all the wealthy people from, government, royalty, they come to your country, lesser to Singapore, but I think mostly to your country. They deliver their babies, they have their plastic surgeries, they have everything almost done in Thailand. And they also have come for vaccinations because, they just don't trust the vaccinations in Cambodia sometimes. What does Thailand do to assist countries that, in effect, support a lot of the the hospitals and the medical clinics in Thailand? Does Thailand have any sustainable efforts to help Cambodia, which is a neighboring country?
Yeah, this is true that the rich one go to private hospital. So it's not affect any system for the public health system for Laos and Cambodia to the private hospital. And it's a good policy for the government to get, income from private sector. However, the helping with that system for us may be more now for Myanmar because we have migrant worker. Like in my city is the border of Myanmar. We have 300,000 migrant workers from Myanmar come to work in Chiang Mai city only. So therefore we need another system for health system because they use our public health care system because they are poor. They will affect the UC system. So everyone, now everything's similar to here where you have Spanish language, we have to have Myanmar language everywhere. So now we have to learn from you. However, we set up that everyone who migrant worker, they need to have health insurance. So therefore, health insurance is for migrant worker. Certain amount of money the employers have pay or either themselves pay for health insurance. If not, we are going to have problem. However, with a lot of global traveling, some Western people also, especially pensioners, they know that healthcare system, there's some limit, some hole in the system. They can go to the public hospital for some treatment, which they should not be eligible. But for Thai people, we are so kind, so we cannot regret the patient. So there's a lot of things that we might need to, working along. If aging society, we have our own aging people, we have migrant worker, and we cannot accommodate another people. So this is going to be something that we need to work with. And for my own work, we have been helping with Laos and Cambodia in certain area for training, especially under like my cleft project things. We try to teach the doctor in Myanmar and Laos and Cambodia, if possible, to do their own care for their own people as much as possible. That's what we have been doing.